Bismillahirrahmanirrahim. Assalamu alaikum, and welcome to what I think is possibly the coldest day of the year. Well, it is the middle of winter, is it not? And I guess we've been very fortunate up to now. The days have been pretty mild, but oh my God, it is really, really cold. So if you're thinking of going out, be sure to dress up warmly. And thank goodness also that it is the school holidays, so our little darlings won't be exposed to the bitter cold of midwinter. Okay, so that's it for the weather. Let me tell you what's coming up on the show, and I do hope you'll keep us company right up until 10 o'clock. We'll be talking to an NPO from El Dorado Park. They are going to talk about the difference they're making in the community. They are called Hoi Sauce, of all things, Hoi Sauce. They'll tell us why they've chosen the name and what is it that they're doing to start taking back their streets and saving their community. Also, Wheel Well, I think is what they called. Peggy Mars, the founder of Wheel Well, will be here to talk about children, car seats and car safety. But right now we're going to be looking at psychological issues. We're going to talk bipolar disorder or bipolar. In the past it was called manic depression, but of course it's no longer politically correct to refer to the condition as that. We're now told that we need to refer to it as a bipolar disorder. Clinical psychologist Sam Mtembu is in studio, and she's going to unpack this condition, bipolar disorder. Sam, good morning. Welcome to the program, and great to have you here.
Good morning. Thank you for having me.
Now, you're a clinical psychologist, and we're going to talk bipolar disorder. But of course, we had this very interesting discussion off air. And before we get to bipolar disorder, let's talk about the scope of clinical psychologists in South Africa and possibly globally. I think the thinking is that the scope is very narrow, that you'd have to work in a medical institution like a psychiatric hospital or a hospital per se. But you've told me about your very interesting background and interesting work that you're involved in as a clinical psychologist. So for those psychologists out there watching us this morning, let's give them the good news about the wonderful work of world that is available to them.
So just as you say, the assumption is to think that, the only place that a clinical psychologist can work is the hospital. And that's actually very limiting, because the amount of skill that you do get when you are actually working at the hospital, the public hospitals, and internship or in ComServe, prepare you for the greater world, or I can even say the greater needs of the world. So we're needed in communities, we needed to give back in the university so someone can do clinical psychology and lecture at the same time.
Which is what you're doing part-time as well.
Yes. So it's just a matter of broadening your scope, because mental illness is quite, I can say it's an undiscovered or uncharted terrain, where there's a lot that needs to be put out there, and by clinical psychologists, people who have received the training, spreading out the word and being involved with more community projects, NGOs, all of that. It will be more beneficial for the community.
Tell us what you're doing, because you're not running your own practice currently for various reasons, obviously. So tell us how interesting and varied is the work you're involved in.
Okay, so I'm currently lecturing part-time. It once used to be like a biblical college, but now it's just opened up to more commercial courses, lifespan development. So that's how children are born, what happens in the womb, what kind of teratogens a mother can be exposed to that cause birth defects, which then lead to the things that we later study, like ADHD, bipolar, all the things that come up later on psychologically.
And the age group that you're targeting at during this lecturing?
So usually second years. So second years, it would be around 18, 19,
Right.
20s, yeah.
Okay.
So they then study that, which is one of the foundation modules for psychology. And then on the side, I'm doing a psychiatric hospital, so that's also part-time, where I'm just seeing patients for inpatient therapy. And it's part of a recovery center where it's split into half, where there's a rehab side and a clinical psychology side where patients can receive help.
And that's the sum total. And you do locuming as well?
Yes, locuming and also writing an article. So after I finished my master's, there was quite a lot done in terms of different topics that the masters had. So we're trying to focus on publishing 2 different papers based on that. And just academia as well, thinking of going into doing a PhD at some point.
Oh, good on you. Yeah. Lovely. What an interesting life and what an interesting history. And you would obviously encourage other young people to go into this field. I was talking to someone who counsels at Lifeline, and he was saying to me that it seems that there's almost a glut of psychologists, and more young people seem to be gravitating to studying psychology as a profession, but young people are finding it very difficult to find work. Would you agree with that? And also, what does the corporate space look like? Particularly, I know industrial psychologists get absorbed into the corporate world, but what about clinical psychologists? Is there scope for them in the corporate world? So 2 questions, obviously. Would you encourage young people to go this route? And what does the corporate world look like for clinical psychologists?
I definitely would. It's a long journey. It's a really long journey. I think maybe what actually happens is because only so many people can get accepted into the master's program. A lot of people who have done their psychology degree, even the ones that have done honors, fall by the wayside because of the lack of the amount of people that can be accepted into the program. So it may seem at that point that studying psychology was a waste of time and it wasn't very lucrative. But there's all the other options where people can open up their own NGOs. And like you say, there's the corporate world now, which is opening up their doors a whole lot more to the clinical psychology and psychology side, where, yes, we do have your industrial psychologists that are within the corporation, but there's so much more need for wellness and employee wellness to be particular. So I think there's also another thing, talking about the corporate world, called user design experience, where people who have studied psychology can study IT and then learn how to make the interface of a website or online almost agreeable to someone psychologically. So there's quite a lot of interesting things out there, because psychology and robots, psychology and science, they're coming together a lot, and a lot of studies as well about the psychology of people having pets, dogs and cats, and
I can see that I'm going to have you in studio lots more to unpack all of these interesting concepts that you've just mentioned. So I'd like to explore it further, and I have no doubt in my mind that our viewers would love to hear more. But let's get on to the heart of the matter today, and that is bipolar disorder. Obviously, we're talking about a spectrum disorder, because no 2 people would present in the same way. No 2 people would have, their highs and their lows, and again, present in the same way and also be treated in the same way. Having said that, what exactly is bipolar disorder then?
Okay, so bipolar disorder is characterized, let's just focus on the name itself. So bipolar. So bi meaning 2, and then polar meaning opposites or different points. So what this basically means is that someone will go in between either feeling really happy or high, or just moderately happy or high, and very, very low. And then we often joke around and say that people have mood swings. But this is like describing someone with mood swings on a severe level, on a severe
Absolutely
scale.
Extreme.
Very extreme. So it's a chemical imbalance in the brain, and it's unmistakable when you have a loved one or a friend who has bipolar. It's something that feels so bizarre and it's so extreme that they will know that person, something is not quite right with them. So it's not just your average mood swings, or if someone just has a bad temperament or doesn't get along easily with other people because of introversion or other reasons, but it's really, really, really severe, and the behavior shows that what's going on in this person's brain at the time.
The good news is we're told by people like yourself and other medical professionals that if managed properly, correctly, meds are taken as prescribed on time, etc.,
Yes.
the person can lead a very, very normal life.
Yes.
What can go wrong, and why does it go wrong, apart from the fact that they're not managing, their
the
meds
medication,
correctly?
yeah.
Do you get a situation where the medication needs to be adjusted for some reason or the other? Does that happen?
Yeah, so there's actually quite many reasons why maybe medication wouldn't work, or at that moment that person might have a relapse. Oftentimes, a lot of psychological stresses are overlooked, where bipolar is not just the management of medication, but it's a management of someone's life in the whole comprehensive way of looking at it. So you can take your medication, but the medication only, I can even say, subdues the neurotransmitters to almost behave in a way that a normal brain or a person who doesn't suffer from bipolar would have. But it's also the psychological stresses, because sometimes the psychological stresses, putting strain on the brain coming in, will still override the medication. Or let's say a patient won't take the medication, or there's something that changes in the chemical brain, that then their sleeping patterns start to change and they require a higher dosage of medication. So it's a complete management of life, and lessening the stress, going for the therapy, communicating with the family, because a lot of the time bipolar can be traced back to childhood, and we realize that these people have been put through very extreme circumstances that activated the disorder.
Okay, let's go for an ad break. When we come back, let's talk about, are you born with it? Is it environmental factors that precipitates this condition? And let's also talk signs and symptoms, but right after the ad break. I'm talking to Sam Mthembu. She's a clinical psychologist. We're talking bipolar disorder. And as you heard, we also spoke about the issue around the scope of psychologists and clinical psychologists in the workplace. So we do hope that you found that to be useful information. Don't go away. We will be continuing this discussion right after the ad break. Welcome back. I think the off-air conversations are so very interesting. I need hours on end to get through all of the stuff with my guests. But just a reminder, we are talking to Sam Mthembu. She's a clinical psychologist. We're talking bipolar disorder. So the questions I posed right before the ad break, I presume there's a genetic disposition and also issues around signs and symptoms. And at what stage, let's assume there is a history in my family of bipolar disorder, and that gene gets passed down to one of my children or grandchildren. At what stage would I be able to pick up signs and symptoms, and what would they be to suggest that perhaps that child is presenting with the condition? So I've thrown 4 questions at you, and let's wait for your responses.
Okay, so yes, it is a genetic predisposition. A lot of the time parents pass on the genes for a lot of mental disorders actually have a genetic predisposition, found out through twin studies and so on. So, and then if you know that you, as a parent, you have bipolar, or even in some way you can have a parent with depression, and then somehow your child will fall into the scope of bipolar. So usually the thing to look out for is between the ages of 15 and 22, because a lot of onset of bipolar and a lot of other mental illnesses, like the first onset of schizophrenia and depression, happen between the ages of 15 and 22, mostly from the age of 22 upwards. But we do consider from the age of 15 up to 22 where...
Do we know why? Why that specific age range?
Well, we go back now to developmental psychology, where when a child is growing up, the brain hasn't quite established those connections of then showing that this is how the brain manifests. So because a child's brain is still it's still developing, it's still very neuroplastic, the symptoms of mental illness and the setness of the brain only come out after the person has either been 18, 29, 19 and 20, 22. So usually the brain then is at the stage where a mental disorder can be actually diagnosed. Or else before in childhood, there's a lot going on in the brain. There's a lot of neuroplasticity and a lot of things change in the child brain. So we cannot diagnose so much early these kinds of mental illnesses and disorders. So, and also when someone is, in their 20s or 90s, there's a lot of pressure of them in society. There's a lot of things like substance abuse, things of being exposed to the world that actually bring out those and also studying as well, a lot of pressures of being at university or trying to make a living. And then those pressures almost activate that gene that could have been lying dormant the whole time.
What about ADD and ADHD? Mm-hmm. If your child presents with that condition and is being treated or even left untreated, because a lot of people seem to think that they'll grow out of it, does that suggest that that child's going to possibly present with bipolar or depression or a mental disorder later on in life?
So that's a big debate because often children who have these symptoms do maybe fall under the diagnosis of ADHD, ADD, because that's what's diagnosable at that time. It's very, very rare that you get a clear-cut bipolar diagnosis in a child from a young age, and a lot of clinicians stay away from diagnosing bipolar that early. So you might find that a child does actually have bipolar but has been misdiagnosed ADD or ADHD because that was what's acceptable as a diagnosis. And then later on, the symptoms become clear-cut and it's no longer avoidable, or we can no longer use the excuse that this child is still young. It could be other things. But then a lot of the time, if a clinician is able to tell the difference between an ADD and ADHD diagnosis and if something could be bipolar or not.
Signs and symptoms, we've touched on the mood swings, the extreme mood swings. What else would be playing out in this young adult's life for us to realize that might just be bipolar?
So usually the person will either be very depressed for a certain amount of time. It's also seasonal and it's a cycle. So maybe in the beginning of the year, so let's say the first 3 months of the year, your child is able to register at a university. Everything is going fine. They're attending classes. And then this would be more or less in the manic state or the hypomanic state. And then they would slowly start then spending too much money or going on benders or not sleeping, flights of ideas, saying they have this business idea and they'll stay up all night writing a proposal. They might even engage in risky sexual acts because of the amount of energy and the impulsivity that happens during that stage. And then we swing over to then the depressed side, where they will not engage at all, the school marks will drop, they will not leave. So it actually looks like depression during this time. So during the manic stage, usually patients don't come into the institution during the manic stage because manic, they still have a lot of energy, they're still going. Only when
they have the zest for life.
The zest for life. And only if it spills on towards psychosis does it then become concerning, where someone will actually have hallucinations during that stage. Then we usually see admission during that stage. But most of the time, people with bipolar come in during a depressed stage.
Can you just give us a brief description of when a person just starts bordering on the psychosis? What type of behavior would that be so that loved ones can be alerted to the fact that we have a problem. This person needs to get into hospital or see a medical care practitioner ASAP.
So things like auditory hallucinations. So they'll hear people saying that they want to kill them, or paranoia. So they'll say, no, I'm locking my door because I feel like some people are trying to kill me. Or they'll say, I'm God, I'm powerful, I can read your thoughts, I can change the weather, things like that. So it also spills over into some of the schizophrenic psychosis. And then there are things like, I'll buy your house. So it's just this, these kinds of delusions of grandeur, or having money, or having celebrity status, knowing that, or saying that they're a celebrity, talking to themselves in the room, not coming out, not bathing, a fear of water, or something paranoid linked to something that's going on, linked to the visual hallucinations that they're having, or the auditory hallucinations.
If your loved one resists going into hospital, what do you do? And I'm sure that there are a lot of them that say, I'm okay, there's nothing wrong with me, you're the problem, I'm not the problem. What do you do in a situation like this?
So eventually, if because, you know, even in the bipolar states, there's times of where the brain kind of, it's like an equilibrium where the person
has moments of lucidity.
Yes, like understanding and almost like consciousness. So during that time, usually then family members do agree to go to the hospital. But a lot of the time they need forced admission, where then the police will have to get involved.
Ooh.
And then the EMS services will come, pick them up, then
sedate them possibly.
Yes, sedate them, and then they'll, as soon as they arrive at the facility, they'll get sedated there, and then the family books them in.
How low do they go as far as the depression is concerned? As low as possibly considering or attempting suicide?
So that's depending. So bipolar 1 is generally the one that's got the high highs and the really low lows, and bipolar 2 has bipolar 2 is the one that has the really I'm confusing myself here.
Don't worry about it. So there are two. There's 1 and 2.
Yes.
Why have they been classified as 1 and 2?
Because the 1 has the hypomania, which is not really high, but it's high enough to be a little bit bizarre, where they have too much energy. And it's a low, but it's not a really low where
are they functional enough?
No. So both of these are they're bad. And then they both lead to what you're saying is suicide and the depression during that time. So usually the manic 1, so manic 1 is the really high, really low lows. Bipolar 1, yes, it's the really high highs, really low lows. Those will be really, really, really depressed, to the point where they might be too depressed and not actually have the energy to try and commit suicide. But this does also happen where people do try to commit suicide in that low state. Then we have bipolar 2, where there will be hypomanic and not so hypomanic and not really severely depressed, but they'll have some sort of dysthymia or present like dysthymia. But again, they will also be at risk of committing suicide. So there's a lot of individual factors that come to play when it comes to bipolar.
I should imagine diet, lifestyle plays a huge role in the well-being of people with bipolar disorder, whether it's 1 or 2, and family support structures. So talk to us about diet and the type of medication, and also more importantly, I think this is what's very worrying for a lot of people with the condition, is the side effects of the meds.
The side effects of the medication, it's psychiatry and psychology. We're still trying to look into more how to assist people with bipolar disorder. But the medication aspect of it, because the brain is so complicated, like we were saying earlier, sometimes someone will be on their medication but still have a manic episode or depressive episode where they have to have a hospital admission. So like you say, the diet really helps, and a lot of the time family support and having that therapy. So having something consistent, having something that that almost keeps the brain stable and in a way kind of makes it plateau, instead of triggering those responses of feeling very stressed or feeling very low, where someone might end up taking their own life.
Oh, we have support groups for all sorts of conditions. What about bipolar disorder, and what about the support structure, the loved ones? It must be really draining and really hard on them to deal with their person. I might just hasten to add that I know several people who suffer from bipolar disorder, but they're so well managed that they're truly leading very fulfilled lives, them and their families. But then there are, on the opposite end of the spectrum, people who have almost no future. Kind of wonder, what's her future going to be like if at this age in her young adult life, this is what life looks like for her. What's going to happen 10, 20 or 30 years hence?
So, again, I want to go back to childhood. We need to remember that some people who have bipolar or the way it gets triggered is very extreme circumstances in childhood. So there's a lot to unpack. And this is the reason why you get people who are able to manage it really well, because they go for the therapy, they have that support, and they're able to unpack the years of strain that their brain has received. So, and let's say now for those speaking on the other end is, let's say maybe someone has bipolar induced by substance. So let's say they tried a street drug, or even sometimes reaction to certain medication, or even in a way a medical condition that can bring on a mental disorder.
But the street drug or any other medical medicine that brings on you know what I'm trying to
Yes.
say, precipitates the condition,
Yes.
means that there was an underlying, it was there lying dormant, and this just triggered it.
So you do get cases where someone maybe didn't have the gene. Well, there's, in a lot of cases, it's really difficult to tell. We just say someone has the gene because we know a parent has the gene. There's no way of actually honing in on the brain and seeing, oh, there's the bipolar gene. So a lot of the time, even people who might not even have a depressed member in the family will get bipolar disorder because of a substance. So
the
substances,
substance would create the imbalance in their brain.
Yes, so it mimics the same kind of organic bipolar that a person will have. So the people with substances, then it's just about managing substances, managing the reason why they came to the substance, then the bipolar diagnosis. But with people who have a history of either child abuse or not having the kind of situation at home that was then activated that bipolar, it takes a while, and that is why then the family support, what you're saying, the friends, the diet, and also the self-awareness actually plays a huge role in how well they're going to turn out and how well their bipolar will be managed.
And that's where we leave it. Thank you indeed for the insight into this condition, bipolar disorder, Sam Tembu. We do hope we'll be seeing you in future shows right here on ITV.
Okay.
There you have it, bipolar disorder with clinical psychologist Sam Tembu. Still to come, we're going to be talking car safety seats and car safety for the little darlings in our lives, and later on the NGO in El Dorado Park making a difference by taking back their streets. From psychology, we move on to the safety of the little darlings in our lives. We'll be talking to Peggy Mars from an organization called Wheel Well, and it's all about car seats, car safety, and ensuring that our kids are strapped in, even if we're just taking a ride around the block. So let's hear what Peggy Mars has to say about the importance